Regarding my final DM examination cases and spotters and what are the questions that I faced and how was the viva, we will be saying in this video. This might be helpful for the residents who are going to appear for the examination in the near future. So in our center also it was formulated as one long case, two short case, then subsequently there are spotter and grand viva. So the first case I got was the short case and the time allotted was 45 minutes for this case. So the difficulty I faced in this case was the time management. I could not able to complete the examination fully within the stipulated time. I could able to complete only up to the general examination. That was also I could not complete the height, weight and BMI and all, because in the history itself it took a lot of time. So basically the patient was a 60-year-old female, and around 1 month back she started having diarrhea. Subsequently within 1 or 2 days she started developing decreased urine output, for which she went to local hospital where she received around 8 sessions of hemodialysis. Because of the non-improvement she was referred here. On probing the history, there was history suggestive of like bone pain was there and the old age, back pain. Other than that, there is few factors suggestive of like chronic renal involvement in the form of NSAID intake, nocturia was there. So the entire history I took. So if we take the viva, like to the examiner, I have like told regarding I could not complete the systemic examination. Abdominal examination was remaining. They gave me 5 more minutes to complete those. Then subsequently the presentation started. I have completed the entire history. There was no interpretation, no interruption when I presented the entire history. So the history was very important. So at the end of the history, the viva started. Basically, my first differential was pre-renal, aka stage 3 pre-renal. The second was multiple myeloma. The questions were like why I was saying AKI, what is AKI, and why the first differential of pre-renal was kept. And in this patient, why the multiple myeloma was like suspected, points favoring and points against, and what are the stages of AKI. Then the question came, like whatever the question I am remembering that I am discussing over here, what are the varied manifestations of multiple myeloma with respect to the kidney. Like we have to tell and elaborate about cast nephropathy, PGNMID, and even hypercalcemia induced renal damage. And then question went to hypercalcemia management, how to like prevent the kidney injury with respect to hypercalcemia. Then cast nephropathy, what are the risk factors for the cast nephropathy, how to diagnose, when to do biopsy, when to do renal biopsy in the case of multiple myeloma, and the diagnostic criteria for MGUS. Then the questions were around with respect to the pre-renal component, how common in this age group, and what are all the uh, pathophysiological mechanisms involved in the pre-renal injury. And other questions were in the form of bone marrow biopsy, when to consider, and investigations wise, what are the investigation I will do, and what are all the expected findings, and what is the sensitivity of serum protein electrophoresis, serum immunofixation, and free light chain assay. Then question came, what is non-resolving AKI? Since the patient had no urine output after a period of around 1 month, what is non-resolving AKI? How to plan the vascular access? Then questions were around the treatment. What treatment to plan? In this patient, what treatment I will plan? And what are the chances of recovery? Does gas nephropathy have good prognosis? And like when to consider renal transplant, suppose if the patient is having like going into CKD, secondary to multiple myeloma, when to plan renal transplant, and what is the outcome of the renal transplant in these cases. And then they asked regarding, like, since it was a non-resolving AKI, like uh, what are all the risk factors for non-resolving AKI and post-transplant recurrence with respect to this multiple myeloma, and the treatment, how long to give with respect to the multiple myeloma induced like renal damage, and what is the age group common for the varied multiple myeloma related manifestations, and a few trials related to the AKI dialysis initiation, when to start dialysis. So these were all the important questions with respect to the first case. Then after this first case, I got the second case, and this patient is basically a glomerulonephritis patient. She's a 30-year-old female. Around 4 years back, she started developing the features of autoimmune features like Reynolds phenomena, joint pain, ILD, for which she received steroid, and subsequently she was on irregular treatment. No evidence of any renal involvement during that time. And subsequently, this year in 2022, she started developing renal dysfunction, which is of acute onset, and received around one hemodialysis, and she underwent renal biopsy and received around 4 times of rituximab. Then she was kept on oral steroids. This was the short summary of the history. And in this patient, on examination, there was a finding of tight skin, that lips, fingernails were like almost dry, and skin was so tight. Fingertip ulcerations were present. On chest examination, there were bilateral, very minimal crepitations were present. So this is basically a rapidly progressive glomerulonephritis. I gave the first differential as oncovasculitis in view of like rituximab. What are the summary I have told there, since the patient received rituximab 4 times, I gave importance to that history. So like in this also I presented the history. There was no much interruption during the presentation. The questions or viva started as soon as I started telling the differential syndromic diagnosis and the differential after the history part. Then subsequently during the examination also they have asked for all the important finding, whether I am able to pick up those findings or not. And the viva started with why not it is SLE. Like what is the first differential diagnosis on the background of ILD, the patient having features of scleroderma. What are the renal manifestations of scleroderma? What are the renal manifestation mixed connective tissue disease? What is the manifestation of rheumatoid arthritis? And is it possible to have SLE if we take apart the rituximab history? Does SLE presents like this? Since I have told as differential diagnosis is ANCA-associated vasculitis, first differential, then like here the question started with respect to does ANCA-associated vasculitis usually present like this? What is the age group, and what are all the varied types of this one and varied manifestation, systemic manifestation in which vasculitis which is more common? Since the patient 4 years back started having ILD, then after the 4th year she started having this renal involvement. They asked does ANCA usually presents like this? Then how many cases of like these kind of presentation you have seen in ANCA? And with respect to the lung manifestation and the SLE, and basically all the viva revolved around here only, since the differential was SLA, MCTD, and ANCA-associated vasculitis. What investigation to do? MCTD, what is the renal manifestation? Suppose if it is a scleroderma renal crisis, how to manifest? And what is the pathophysiological entity in renal scleroderma renal crisis? And how to manage that? What are the histopathological finding in case of TMA, acute TMA, and chronic TMA? Basically, in this case, the viva didn't went till the treatment because the viva was revolving around here only. Since my performance was not up to uh, I'm not able to substantiate the points favoring the first differential points against the first differential. So the Viva was revolving around here. What was the investigation you will do? What is the investigation of choice and classification of this RPGN? What are the causes of RPRF and any trials of SLE with rituximab? Why there is a poor response of rituximab in SLE induced lupus nephritis? These were all the few important questions that I could remember. And the third case was also like this was the major case. Like for the DM nephrology exam, always the post-transplant case is the major or the long case. In this, for this also, yeah, all candidates will have only 45 minutes. Since it was a third case, I got a little bit more time. And basically, this patient was a 36-year-old male who got almost all the complication. The patient is basically a ABO incompatible transplant with a difficult vascular access with the multiple uh, ICV cannulations, 2 AV fistula failure, 1 femoral vein catheterization, and in the immediate post-op he underwent biopsy. He developed pneumonia, UTI, endophthalmitis, diarrhea over a period of like this is over the first month, second month, and third or fourth month. This was the overall summary. In this patient also managing the time was little bit difficult because if it is the first case, completing this within 45 minutes will be very difficult unless you are very good at history taking. So try to practice the history taking. In this, the almost Viva covered almost all the like each and every component of the case. The Viva started with what is the basic disease of this patient, why you are saying this is the basic disease, and what is the common causes of CKD in the age group of 30 to 40. And since ABO incompatible is there, incompatible transplant, what is the protocol being followed in our unit for ABO incompatible transplant? What is the standards, Indian standards? What is the titer which is recommended, below which it should not be done? When to use ATG? When to use basiliximab for induction? And with respect to the difficult vascular access, what is the European vascular guideline says regarding uh, preferred vein for permacath insertion? If IJV is blocked, what is the preferred one? As per the guidelines, it is the external jugular vein before going to the opposite side. That was the particular question. And with respect to the AV fistula, the question came like, how will you assess the adequacy? What's the Doppler parameters? And what might lead to this multiple vascular access failure in this patient? And the questions revolved around the basic disease, how long usually it takes for the patient to develop CKD. And since it is ABO incompatible, they asked about the family members and how to prefer whether ABO incompatible transplant or ABO compatible with high HLA mismatch. What I will prefer and why. So these are the questions we have to be aware of. And after completing this difficult vascular access part, question revolved around the transplant. What is that? Few questions about warm ischemia time, cold ischemia time, and then comes the immediate post-op period. What is the urine output? Why the urine output is high in the immediate post-op period? What is the target tacrolimus dose? When not to prefer tacrolimus? What other drugs you will prefer? Why the biopsy was done on the 5th day? What is delayed graft function? What is early graft function? And there were three with respect to the graft dysfunction, delayed graft function, and two more like that questions were asked with respect to the indication for biopsy in the immediate post-transplant period, and what are the drug modification which were done, and after the biopsy, what are the modification in the drugs required, like how I interpreted it, and the questions revolved around CMV, how to diagnose, what is the importance of donor CMV, what is the prophylaxis, how long to give, almost all the questions related to CMV. What is the investigation of choice, whether it is being checked in international unit or number of copies. Then the question revolved around PKV virus, What is the usual manifestation? Does this graph function might be secondary to BKV or not? What is the screening protocol of BKV? Then regarding the pneumonia, what is the common organisms? Why do you think the patient might have developed pneumonia? Risk factors for UTI in the post-transplant period, common organisms, time period, and with respect to the diarrhea, they asked about direct study, how the patient responded, what was the modification done in MMF, why the modification is required, what is the difference between MMF salt and MMF, and with respect to endophthalmitis, what is the most common organism, and how to treat that, what is the target dose to keep, and this patient also had graft dysfunction, like at the end of the post-operative month, so like I think it was 6. Like almost each and every complication he had, what is the reason for graft dysfunction? How to manage if it is a acute cellular rejection? How to manage if it is an antibody-mediated rejection? So these many, like almost they have covered the entire post-transplant areas. In this case, like the viva lasted around 1 to 2 hours. In this case, since the history was clear, I was able to manage to answer these questions. So subsequently, they asked about the Indian trials with respect to diarrhea, like from which center it was done, and like in this case, almost these were all the important questions with respect to the cases. Then the next session was the spotters. Basically, they have given us the slide. We have to do the microscopic adjustment by ourselves. We have to see in the scanner view. Like microscope will be having 4 views: scanner view, low power, high power, and the oil immersion. So first see at the scanner view, then low power, high power. This is 4x, 10x, 40x. This you have to be clear. They will definitely ask what is scanner view, what for it, what for the low power view, and what for the high power view. Oil immersion we won't use. So the adjustment you should practice before the examination only. So in the first slide I got the case of like crescentic glomerulonephritis. Basically one line history was written. 30-year-old female with autoimmune features and renal dysfunction. This was kept, and the slide, whatever I could make out, I am able to see some presence. So I present, like I have mentioned, what is the stain you have to tell, how many glomeruli I have seen, and out of the glomeruli, how is the interstitium, how is the vascularity, that we have to. In the second case, basically it was a 62-year-old male with sudden onset renal dysfunction, and in the past time we see a eosinophilic material within the tubule. So it was like I have told it as a cast nephropathy. So 2 slides will be given in the examination format that we underwent. We received 2 slides and 2 spot diagnosis we have to make by adjusting the microscope, and we have to describe with respect to the findings. Cast nephropathy, how was the tubules, what is the giant cell formation, why the giant cells are formed. The viva started from here only. Few questions with respect to cast nephropathy, and what is the apple red bifringence, like how to differentiate it from nodular glomerulosclerosis. Few questions with respect to diabetes amyloidosis, and these, how will you differentiate. These were with respect to the slides. Then subsequently the grand viva. In the grand viva, in the imaging section, I received a CT venography of a patient who had central venous stenosis, like with central venous stenosis, which resulted in like high pressure, outflow in aneurysm, and almost it was looking very big veins. Basically, it was a central venous stenosis associated with outflow tract dilatations and AV fistula aneurysm. The question with respect to this was, what are the alarms in the dialysis machine, and what are the alarms you will get if there is a outflow tract obstruction? How to monitor for AV fistula adequacy? What are the monitors? What are the alarms which will go if the patient is having inflow problem? How to check the recirculation? Is there any other way of managing this outflow tract obstruction. What is the manifestation of these outflow tract obstruction? Suppose if patient is having only swelling, what are the other manifestation? There's inadequate dialysis can occur because of the recirculation, because there is outflow tract obstruction, so there's a high chance of recirculation. And how to manage the central venous stenosis? These were the few questions with respect to the imaging. And then questions were about with respect to RO what plan they have asked. Suppose if I am setting a new dialysis unit, whether you will prefer a storage tank or not, what material the storage tank should made up of, and what shape, what are the guidelines for the storage tank, and how to set up the loop system, whether I will prefer the storage tank or not, and what is green nephrology, and how to implicate in our unit, and what is the RO water rejection rate, what are the various filters which are uh, available in the like RO water plant for a dialysis unit, whether you will prefer endotoxin filter or not, and how to use the rejected water, whether you can use it for drinking or not. This was also one of the questions. And other than that, what is that like ideally when to check the chlorine level, when to check for microbiological culture? That's only this I could remember with respect to water plant they have asked. And a few questions with respect to biopsy. Since the biopsy gun was there, they have asked with respect to indications, contraindication, and how many biopsies I have did, and how to manage the post-biopsy date. These were the questions. Then few questions related to my thesis they have asked, how I formulated, like what are the previous study result, few questions with respect to thesis. And finally, DTPA image they gave. What are all the indications of DTPA, and like how they will do, and when cystoscopy does it have any clue? Basically, there was a question where they have told if the patient is having a undetected kidney in the ultrasound, how to find the patient is not having any functional kidney. Basically, how to prove the patient is having single functional kidney if DTP is not done. What is the other method? You can do the cystoscopy to look for the ureter. If ureter opening is present on the both sides, that means kidney somewhere might be there and it might be functional. Suppose if only one ureter is there, is congenital unilateral kidney. So these were all the questions, whatever I could remember from my final DM exams. So this video might be helpful only for those whose exam is very much nearby. So all the best for your exam. Suppose if you want answer for any of the questions, or if you want any of these three particular case have to be discussed elaborately, please let me know. I will try to make a video on that.